Hello and welcome to today's webinar. Thanks for coming. My name is Samantha Winters. I oversee marketing for Purview, including how to go to market with your second opinion program. So I will be hosting today's topic. Before we get started, a few housekeeping things. Microphones are muted. However, we love it when you're interactive, so we welcome you to type in questions into the Q&A box at any time. If we don't get to it while we're discussing the topic, we will circle back at the end. While I'm introducing the topic, I'm going to launch a brief poll. There we go. And this really just helps us to get to know you all better, where you are in kind of thinking about starting a second opinion program. So while you're doing that, what we're all here for today. So we are here to talk about getting started with second opinions through a pilot. We're going to talk about the differences between fully mature programs and a pilot, as well as how to be mindful of your long-term goals when launching your pilot, what specialties to consider, which geographies to think about, case administration to support, compliance, how to market the program, and so forth. We have Les Trackman here with us, who we often refer to as our second opinion evangelist. He's also our legal expert on issuing second opinions across state lines. So you may have already attended some of the other webinars on that topic on legal and compliance. Welcome, Les.
Thanks, Samantha.
We also have Josh DiBartolo with us, Purview's Chief Operating Officer. Josh has worked with a host of large hospital systems to bring them online with our second opinion programs. He oversees case management and can speak a lot to what has worked and what hasn't worked. Welcome, Josh.
Thanks for having me, Samantha.
All right, so between the three of us, we are going to cover what I'll call the trifecta, or the three main topics that we believe make or break the success of these programs. And that is marketing and positioning, operationally supporting your programs, and the legal strategies. So let's just set the table for getting into this topic and start with why. Why start a second opinion program in the first place? And I'm going to kick that one over to our evangelist, who I would also describe as the mother of ExpertView, or founder, the software that we use to support these. What would you say, Les?
I didn't think you were able to pull that one off, Samantha, calling me the mother of the product. Yeah, thanks for that. So the second opinion programs, remote second opinion programs specifically, have already been found to provide great benefits to the institutions that have begun to utilize them. The things generally that second opinions can do is they can expand your geography beyond just the bricks and mortar of your hospital, and even beyond your local area or even your regional area. They can ultimately be worldwide. And second, they can extend your brand. So for people who don't know about you outside of your general region, perhaps because your name reflects that region, they can find out about you. And we've seen great benefits accrue to the hospitals that have used remote programs like this to gain notoriety, worldwide notoriety in some cases.
Yeah. Anything to add?
Sure. Yeah, I'll add to it. You know, from the patient side of things, what you're able to do is give the patients an avenue to gain access to expert care that your facility offers that they might not otherwise have access to. So, you know, I grew up in a rural area, not a lot of great hospitals in that region. You know, a program like this allows you to not have those rural healthcare disparities, in that you can still access some of the best in the world. So from a health equity standpoint, I think it can also prove to be a really valuable thing for your hospital, both from a brand as well as a functionality standpoint.
Right, exactly. We always say disease doesn't discriminate, it doesn't care what zip code you're in. And so if you're a specialist and you deal with a rare or something especially complex, you know, you don't necessarily have all of those patients in your local zip code and vice versa. So good for those reasons. Okay, so let's jump to what is the difference between a fully mature program and starting off with a pilot. Maybe Josh, you don't mind kicking us off on this one?
Sure. So we've seen a lot of programs come in and have success starting with a hospital-wide program. It takes a lot of coordination, takes a lot of buy-in from different departments, and sometimes there are RFPs, sometimes there are large scale projects that need to happen. Been on calls with 30, 40 people to get programs up and going. The benefit of starting with a pilot program, you can start smaller and start, we say, as small as a single division or even a single doctor. You can look at really what your program does well and do kind of a test drive by identifying something that maybe you already have a specific expertise in, or something that you believe is attractive for your hospital that you can get the word out about. And you can start with that one organization, put your effort on in that one division, and kind of expand from there. So I think the program itself is very similar. The software is similar. You get to test all of those things out, but you can come in at a lower lift is kind of what I would say to begin things. And I'll kick it over to Les to add on.
Yeah, and from a compliance point of view, what we see with many hospitals that we encounter for the first time is that there are physicians already informally doing these second opinions. Sometimes, maybe usually not doing them for remuneration, so for free. And that's great. And it does provide that benefit to the person who's receiving it. But there's a lot of risk that's included with that, including the interstate licensure that we talked about in the webinar last time. So a program kind of knits this all together, puts it into a more formalized kind of environment without requiring a big corporate strategic decision to get it done. So it's an easy way to get back into compliance real quickly.
Great. Now, how would you two describe what types of organizations are best suited for online second opinion programs?
Yeah, I think similar to where I was going with the last answer is if you have as an organization something that you're specifically good at, something that you do differently than other people, whether that's a technology, a service, a process, maybe a clinical trial, maybe you are offering a certain type of procedure that other facilities don't. That's always a great place to start. And we see people set up things that look almost like pre-surgical screening programs, pre-admission programs for those types of departments. And they can both accept cases for a full second opinion, which might be like a written opinion that can be rendered, and then the patient can apply it locally. Or if you have patients that are just looking to say, hey, am I a candidate for your surgery? Am I a candidate for your program? Rather than these things kind of flying in all different directions, you can kind of consolidate that into a single place and then stay compliant by making sure that you're tracking all that. And the other thing that's nice is that by being able to track that, your physicians also can get credit because then you have a log of who's doing what. And so we've seen facilities do things like issue RVUs for their physicians or give them clinic time, different things like that. And so it can help coordinate all those efforts. And so really, if you have something like that that's already going, that you already have some expertise or something that you want to be known for, those are all really good places to start. And then I also say just geographically, if you have a target, like you're in a specific geography and you're trying to expand your footprint into another area, that might also help determine where you want to start with which pilots based on what your reach might look like as you go forward.
What about the size of these programs? I feel like we get a lot of interest from everything from large hospital systems to small practices.
Yeah, I think that's a great point. So these aren't just for large organizations, although the pilot does sort of bring it down to size and make it more digestible, at least to start for the large organizations. But for a smaller organization, that's we'll call it a subspecialty specific organization, this can be perfect because although we call them pilots, they could be actually the exact right size for one of those organizations. It might be that there is a single subspecialty within an organization, and that can be set up as an organization that can provide second opinions across state lines, just like a large hospital can.
Yeah,
Right.
just to piggyback on that, we have organizations, that, like I said, that are very broad in the scope, but we have some that are all the way down to just a single expert that's running the whole program. You can, with the way that the software is designed, it can scale up or down for those use cases. You can have a single expert play the whole role if that's where you're at from if you're at a standalone practice or in a division where you just wanted to try this out. We've seen organizations get applying for grants and funding and things in different ways that for their specific program, for their specific department, and using this out, putting the second opinion program as part of that to expand their reach of their individual offering. So yeah, I think it can be really tailored to your needs.
Yeah. And I think, Josh, you've seen this happen more over time where these have evolved to become a way to offer access through pre-surgical screening, potentially clinical trials, and other programs as well. Is that right?
Yeah, absolutely. I think we see those use cases as well as kind of curbside consults where we have physicians submitting. We have an organization that does cancer reviews on a curbside consult approach where physicians can write in, get that review and that direct conversation with the expert physician, and this provides a real seamless way to have all of those records in one place while you're able to have that physician to physician communication as well. So we have, and that can also be another great place to think about spinning up a program because you already have some of those connections with some of those other facilities.
Great. That kind of steps into the next topic, which is how to identify the best specialties for programs like these. We get a lot of questions around this. I think you kind of answered it already, but anything to add to what you just said?
We see it across the board. I think anytime there is a complex condition, and whether that's, orthopedics, oncology, neurology, all of these, different, the ologies, any of them can really have complex cases that have a lot of what we call dense diagnostic data sets, digital imaging, digital pathology, EHR extracts, anything that you're pulling in a lot of prior records to, and that you need to have a lot of things reviewed. That's where the system really has a lot of value because it coordinates all that. We have dynamic ways of pulling in records and uploading records that are really seamless and have built-in web viewers and things for that purpose. So if you got a lot of data, I'd say those are really great places to start. If you've got rare conditions, complex conditions, those are good ones because the higher the complexity or the rarer the disease, the less likely the first doctor you go to is going to be, maybe getting it completely correct. I mean, so you've got situations where, we have doctors who are working on conditions that might only affect, 100 or 200 people a year. So if you're in a rural location on one side of the country and you go into your local hospital, are they really going to know about those types of orphan conditions natively? Probably not. And so being able to get into a program remotely is, I think, of a lot of value. And that's where you can spin up a program like this. And we see, honestly, the more specific you get in some of those, sometimes the more value you have in being able to reach a higher conversion of the audience that you're attracting.
Right. You're nodding your head less. Anything to add to that?
When Josh said the more specific, the more important this might be, that I think is a real that resounds with what we're seeing from our client base. So we often get contacted by individual physicians who are specialists in a very, very narrow area. And pre-pandemic, they were permitted to practice wherever they wanted to geographically. And then post-pandemic, they've come back to wherever you're licensed, you can practice. In some cases, that's stifling for these doctors. And we've had some reach out to us and say, hey, can you help us? Does a program like this work? And those are the kind of specialties that are really well suited for an online second opinion program.
Yeah. Well, you just stepped into the next question, which really is, are physicians on board? And I agree. It seems like more often than not, it is a specialty physician that's the driving force behind getting one of these programs started.
Yeah.
And to add to what you were saying, Josh, in addition to those rare and complex conditions, sometimes it's also as simple as you have a physician that handles a procedure differently than maybe their peers and the rest of the industry do. it's less invasive or something like that. And so we've seen little things like that be those differentiators that attract patients to certain specialties.
Sure, absolutely. Les, you were going to say something?
I was going to say we often affectionately refer to some of these physicians as rock star docs, and oftentimes they are the ones who are going to their administration and saying, "Hey, we really need to do this." And oftentimes the hospitals, not just to keep these doctors happy, but to make sure that their practices are as robust as possible, are ones to look at it and say, "Hey, this might be a great idea. Maybe we should do this." And so a lot of our programs are initially driven by physicians.
Right.
I think that's a great point. I think we get a lot of physician champions, we'd like to call them, that are looking for a better way to do things they're already doing, or looking to expand their reach more broadly. And in both those cases, having a program around it, having a process around it, can help meet things like, licensure, can manage the records intake, which can be a headache. And I think, that's one of the places where I think the physician buy-in definitely comes in. If you have a program that is already trying to do this ad hoc, and you give them a system, the physicians tend to really appreciate that. If you have a program that you're trying to bring physicians along, that's where, I think we've seen other facilities get creative in how to get the divisions and the specific physicians involved. And we've seen them, as I think I mentioned before, we've seen them give them RVU credits. We've seen them give them credit toward clinic time. We've seen the divisions actually get compensated when these come through. And a lot of these programs are tracking, the downstream revenue that these things lead to the patients and conversions. And so the departments end up getting credit for that as well, obviously, when patients are converting in person. So I do think the physicians tend to, for that reason, but also just because a lot of these physicians that we see that are these, rock star doctors, as Les has said, they're those rock star doctors for a reason. They're really good at what they do, and that is something they want to share. They want to get that out. And we've seen many cases where patients have been able to get access to an expert where they would have otherwise not had access. And that's what it's all about, right? Being able to extend that reach and getting the patients a better diagnosis at the end of the day.
Right. So how do you think if an organization wants to start a second opinion program, but they haven't heard from a physician yet that has expressed interest, how would you suggest uncovering who those physician champions could be?
I think similar to what we were talking about before. I mean, your hospital or your practice probably knows who some of these people are. Your marketing team probably has an idea of some of the things you want to promote. And so if you're looking at some of those, you can start to draw some circles around who fits in those buckets. Where do you want to be going as an organization? You might have ideas, on how you're addressing the competition or how you're reaching certain geographies. And so that can help infer which departments you might want to target. But also, I think when you pull the layers of the onion back, you'll probably have a good idea of who some of these physicians are that are attracting business to you today, and how you can better even leverage their value to the organization. And that's how you can maybe start weeding some of it out.
Yeah, I think you can also just you can ask around and see who kind of fits some of the things that we've been talking about and who's interested.
Sure.
Okay, so let's jump to the next exciting topic that we talk a lot about. So say you have a team that's interested in starting a second opinion program or pre-surgical consult type of program. You have physicians that are a driving force, they're interested. And so you're ready to move forward, but obviously you have to bring it to your legal team first. Les, this one's for you. How do you suggest getting started?
Yeah. So we often find that the legal team either proactively, when confronted with a remote second opinion program, or just in general has set the tone in the hospital that post pandemic, the only geographies that physicians can work in are ones in which they physically have a license. So we often find that we start from that point of view. And again, if a program is driven by a physician who perhaps is frustrated by that, we always ask if they would let us have a conversation with their legal or the compliance team. And our goal is simply to introduce them to rules, regulations, legislation that we've seen in almost every state in the country that very specifically permits, if you abide by the process that they require, very specifically permits a physician to give what we call an episodic opinion outside of a state in which they are licensed. And so we want to introduce them to that. And we have a pretty good compendium of laws and regulations in 54 United States and territories that should be enlightening to those physicians. It's something we study carefully because it is our business. It's not necessarily the bailiwick of every lawyer in every hospital. So introducing them to it is usually an enlightening. And we've not failed yet at, when we introduce them to that, to the program, to these kind of things, convincing them that in fact the idea that they can't practice in other states might be a bit dated in those decisions. And so our goal is not to try to convince them, but it is to educate them and enlighten them. And there are lots of hospitals that we can point to that clearly are doing this today and that talk about how they're doing it. And we like to introduce them to those hospitals as well. And sooner or later, we'll be able to convince them that this is something that they very likely can take on.
Right. And I went ahead and popped up the graphic of the map that we use, which kind of shows the difference between how we've interpreted the different states to accept that episodic exemption or not.
Yeah, it's not a just waltz into the state and practice medicine there. There are things that you have to follow, including involving the patient's local physician in the process. There are things like that you need to follow. They're not very invasive, so they're not apply for and pay for a license in each of the states that you want to practice in, which is something that we try to avoid when we can.
Right. So a secondary question comes up quite a bit under compliance, which is, why can't I just do this in my local EHR system?
It's a related question, so that's great. Obviously, you can physically do it in your EHR system. We highly recommend that you don't, and that's because of this licensure issue. So what you don't want to do is commingle a consult in a state in which your physician is not licensed with the rest of the patients that are in your system, which are all patients that have matriculated, physically come to your facility. And so the licensure laws are completely different. If that patient comes to you, and you're licensed in your state, which obviously you are, that's fully compliant. That should go into your EHR system. What we say is segregate these consults, these remote second opinions, in a separate system unless and until that patient wants to convert, wants to matriculate, wants to come for a procedure to your hospital, and which at that point, you can transfer those records from the separate system. In this case, it might be our system, Expert View, into your EHR system, your Epic or Cerner, whatever that might be. That would be exactly the right way to go about it and keep completely in compliance and keep your records very clean.
Right.
And on the topic, just to add a comment there on the topic of Expert View, you showed that map and it reminded me as well that we have a great analytics tools in the product that show exactly where cases are coming from and track them per case. So as Les mentioned, there might be a requirement that you can only do so many cases per state. This is another way where by operationalizing a system, you're able to track that right in the system. It tracks the number of cases per location, per division, however you want to slice it, right with a visual of the map on it, and we'll give you warnings in the system if things are coming from geographies you've set as excluded. So it gives some nice guardrails on the system as well.
Right.
And one last thing I would add is in pilot programs, it's often very sufficient simply to go to neighboring states and begin your program with neighboring states so that you're slowly expanding that geography. Makes everybody a little more comfortable that we're not just exploding this thing out, but that we have full control over the program. And that's a great way to go to your legal team as well.
Yep. So there's a question, if patients are kept outside of the EHR, what tools or systems are recommended for tracking, or is it as simple as using basic Microsoft tools? I think that's what you were starting to touch on, Josh. So maybe explain that again.
Yeah, so our system Expert View, the way that we leverage it is that, if a patient wants to access your second opinion program or your pre-surgical screening program, this is as I've heard Les say before, a patient with a lowercase p. They're not a patient of your hospital yet, right? So they are interested in becoming a patient, but you may or may not have a patient relationship with them already. And so when they submit into our system, it kind of serves as a buffer. A case gets created. You likely won't have an MRN or anything that you're creating yet because you're keeping that separate from your EHR. And then you run the whole case up until that point where you say, if it's a pre-surgical screen, yes, you're a candidate. Come on in person. Or if it's a second opinion, you might give them their second opinion report. They might never convert and they just stay in that system. But at the moment that any of these conversions happen, we also have, a lot of integrations that we can implement things like push to Ombra, push to Epic, things that enable that case to kind of seamlessly move into your other environments. And so as far as the tracking goes, you can get exports of the data from our system to show you where that is. So to the comment of do I need to track it in Microsoft? The system is doing it for you as far as that tracking component is, but you can export it into something like an Excel if you want to use that in your own business intelligence tools or your own tracking systems as well.
Right. Great. And I don't think we answered this, but how might the legal strategy differ when you're starting with a pilot than going, out to every specialty?
Yeah, so it's probably for me, but there's no actually difference from a legal point of view between a pilot program and a full-blown program. And in fact, one of the things we do is we'll do the full analysis with you to start out with. But as I mentioned, it might be completely appropriate simply to step slowly to your adjacent states. So make sure those adjacent states are states that are compliant in the green, if you will, and what you're seeing on the screen right now, and that we understand exactly what needs to be done there. Let's also get your malpractice insurance in line with that, because we have to bring them along for the ride, if you will, and that makes everybody a little bit more comfortable than saying we're going to sprout this thing everywhere in the country or in the world all at once. So with the pilot program, it's much easier to start small and then grow step by step.
Great. Okay. So moving on, say, you have your rock star physicians, they're driving this. Now your lawyers have signed off on this and you're ready to forge ahead. Let's talk about the logistics a little bit. What kind of support do we need for a pilot program specifically, but we can also talk about as it grows as well.
Yeah, I'll take that one. So from an administrative side, once you've identified the divisions that you want to be running in, say it's one division, multiple divisions, whatever it ends up being, we typically we don't believe that there's a lot of overhead in learning how to use our software. It's pretty straightforward, pretty easy, and intuitive. It's been designed with a lot of user feedback, customer feedback. We take that very seriously. And so we're happy to train people up on the use of the software. Um, and the main administrative components, if it's something that you're already running and you're trying to operationalize it, this might actually be less work than you're currently doing. If it's something that you haven't yet dipped your toes into, something like running a second opinion program or a pre-surgical screening program, the main elements are you're going to get patients that are going to submit into the system, and typically that's through an intake form that we have available, might be linked from your department page. We'll talk in this case as if this is a pilot program running with one division. So say we link off of your division page, it links to the intake form. It's going to be branded for your hospital, but it'll actually be Purview's system at that point. They'll fill out their information. It'll create a case in the Expert View product. At that point, typically the administrator would have some level of screening questions they'd want to pass that case through. Are they in a geography that we're accepting cases? Are they in the right place? Like, is this somebody that's reaching out for a different type of program? Is it truly requesting a second opinion? Are they looking for something we can provide? And other questions based on your organization. Maybe are they hospitalized? Are they not hospitalized? Things like that. Maybe if it's urgent, you move them somewhere else. But once you do that level of screening, we typically would suggest there's some type of an intake with the patient. So usually an intake phone call happens between administrator and a patient to get any of the additional details. What are they looking for? What are the specific questions? We tend to see patients submit at one of kind of 2 points. Either they've just been diagnosed with something and they don't know what to do. And so they're asking kind of broadly. They may not even know the right questions to ask. Or a second use case is they've been diagnosed and it's the treatment plan that's not typically working. And they're coming to your organization saying, hey, what can I do differently? Do you have any recommendations? So you aggregate those questions, you maybe help them in that process, and then the case gets accepted or rejected at that point in time, and then you're going to go and do records collections. You pull in prior records, and then ultimately organize the information that you've got and submit that for review to an expert. And so that's kind of the main elements that are on an administrator to run the product. But what Purview does as well is if you don't have somebody that is able to do that, we have what we call adaptive services as well, where we'll do as much or as little of that as you would like. And so that typically ends up being, a Purview nurse practitioner can call and do an intake with the patient. We would conduct the records aggregation. We'd essentially administer our own software. And so we can work with you again as much or as little as you have. You might already have a team that runs this. You might already have an individual that's doing this, or you might not, and we can work with you at any of those points. So hopefully that answered what you were looking for on that one, Samantha.
Yeah, that's great. But I would say part of that topic, we often get another question, which is, you kind of describe this process that needs a point person sometimes to coordinate between the hospital and the team, or the organization and the team. And I'm not so sure that we always need a full-time person for this. We get a lot of questions around whether you really need to hire someone for that. So maybe you can speak to that a little bit.
Yeah, I would typically say you don't need to hire out of the gate if you're already doing this. For sure, this is probably going to be easier than what you're currently doing, because you're probably currently grabbing records from all different places and coordinating emails. And right now you just say, send them a link, and then they're going to submit through an intake form, and it coordinates the process a lot more. So in that case, it's just identifying who's already doing the work and training them up on the system. If you don't have someone today that is currently doing that, or you're not currently running a process, like I said, we can provide those services. So you don't need to hire somebody. We can offer those as a service, if that's something you're interested in. But we also can typically find a point person within a department that's already serving as kind of some level of patient coordination, or coordination with the facilities, that ends up being our point person to set some standards for what gets accepted and what gets rejected as far as cases go.
Exactly. I think we see that with some of the divisions that we plug right into. They usually have someone that's kind of directing which physicians write for which case that comes in, and it's something small that they can take on.
Now, if you do scale, which was the second half of your question, if you scale and you end up with many different, divisions, you run in a full hospital, then you might be thinking, hey, it might be time to try and have someone that coordinates the intake of all the program or oversees levels of the program and things like that. I think what we're talking about today with the pilot is we're saying you can do it without that hire, test it out, and then if you get to a point where you want to scale it, you can make that hire later down the road if it's something that is right for your organization.
Right. That makes sense. Okay, so let's talk about ROI. If you're spending time writing opinions and handling case administration, you probably want to know that some patients are eventually going to come in person. So maybe Les, you can talk a little bit about ROI, maybe starting with how would you measure ROI?
Yeah, so measuring the ROI is pretty straightforward. You'll have the totality of the expenditures that you're going to incur, the incremental ones to put together the program, which might be a software platform, it might be some administrative help, and it might be some stipends that you're going to pay to your doctors. You wrap all those together and you offset that against what are you getting in return. So what is the revenue that comes in? Typically, these programs, pilots or not, are paid for out of pocket by your patients. So these are not, they might be reimbursable in some manner, but most of the hospitals, in fact, all the hospitals we work with, do not take insurance reimbursement for the vast majority of what these second opinions entail. So the out-of-pocket will help to pay for some of this, but that's not going to really make you profitable. It might make you break even with a program like this, but it's not going to give you a true return on your investment. What you said, Samantha, I think is the key to this is you need, or you anticipate that some of these will convert into procedures, will convert into something where they come to your hospital for inpatient, if you will, or something of that nature. And with that, in a pilot program, our experience is that one conversion in your first year will very likely give you a return on your investment because the program costs are relatively low. And over the long run, the course of a couple of years, if you're running a pilot program, you will very likely get more conversions than that. The going rate in the industry, and of course it differs based upon your geography, based upon your current brand, and based upon the subspecialties that you're exposing to the marketplace. But the conversion rates generally are about 20%. So about 1 out of every 5 patients in our typical remote second opinion program actually matriculate at that hospital. So arguably, if you're getting 5 patients in your first year, you likely are running a positive return on your investment in one of these programs.
Great. So first year, that was my next question, is how long does that usually take? And I would agree with that. You're usually at least seeing one convert from a small program in the first year.
Yeah, I think you're going to see more than one. You'll see. I think you're going to see many more than one, depending upon what the number of opinions that you actually are writing. But let's just assume a small program does 2 or 3 a month. You do 2 or 3 a month over the course of a year, you're going to get to 20 something. And the likelihood, again, is 1 in 5 of those are going to convert. So you'll be way over that one, even in a small program, even in your first year. We've had one client that started out in their first year, and they had a 10x in their very first year. They had a 10x return on their investment, and that is not an anomaly. That's reality of what they did. Now, they ran a really good program with a lot of things that I think you're going to talk about next in terms of how they marketed it. But you can, and you very likely will receive a return on your investment in a very immediate period of time.
And I'd just add to that as well. A couple caveats to the numbers and the percentages of conversion that you're talking about are for remote second opinion programs in general. If you are doing things like pre-surgical screening, you're also getting a more filtered, self-selected group of patients because they're already very targeted, knowing they want to reach out to your facility for a specific surgery or for a specific program. So we see conversion rates in those types of programs actually higher than that as well, because it's like I said, it's a self-selected group. So that's kind of one add-on. And the second is that we actually see something that people often don't think about when they initially are thinking about conversions for second opinions. We think about, okay, we're gonna get some submissions in the door. So we get 10 submissions. Say half of them meet the criteria to be reviewed, and then out of those 5, we're saying one of those 5 ends up being a downstream conversion. Well, those first 5 that you rejected don't just go away. You've just told them, all you've done is told them this isn't the avenue. A remote second opinion isn't the avenue. We're connecting those to wherever the appropriate point in the hospital typically is. So maybe they're coming from a geography that you don't support. And we actually see sometimes a higher conversion of those patients coming in person because remote second opinion isn't available to them. They're actually just traveling in person and ending up with a conversion that way as well. So don't sleep on those ones, you'd say, right? Like those ones over there end up actually being quite valuable to your program. And we've seen in some organizations that the conversion rate from rejected cases is actually higher than the conversion rate of full second opinion cases. And that being because a second opinion, you've given them the report and they might be able to apply that locally with their local physician. These other group that are rejected only have the option, if they want to get to you, to actually seek out another way to get to your facility, whether that's telehealth or some in-person or some other avenue. So anyway, just wanted to add that as well, that the conversions are coming from a few different places when you think about these programs.
Yeah, and if you do a really good job building in how you want to redirect those patients based on the different circumstances, I know, Josh, you always show the playbook, and which is a good workflow of how the program's going to run. If you have all of those circumstances laid out, it's really easy to direct them to the different parts of the hospital. So I was just going to add to your conversion rate being higher, that the other reason it's so much higher is because it's so high. For some hospitals, it's like 75% of those cases that don't actually come as a second opinion will go to other services in the hospital.
Yeah,
So
definitely seen it that high.
yeah. So there's a question on marketing. So let's jump into marketing and see if we can cover that. I'm going to kick off this topic, and then maybe you guys could jump in. I'm sure I'll forget one or two things. But I'll start by just reminding the audience that marketing teams like these programs because they grow that brand recognition beyond the local area and really help your organization to become more nationally or internationally recognized. So before I jump into kind of the marketing tasks, the main difference between a pilot and a more mature program is really that that pilot is, again, more narrowly focused on those specialties that you're starting with. But the most important part of marketing, any second opinion program, we always say this until we're blue in the face, but it's really just raising awareness. Their second opinions are not something that every hospital offers. So patients don't always know that getting a second opinion from you is even an option. So the first step is really spreading the word. And the second piece of that is making it easy to find your second opinion program. So placing call to actions, or as we say in marketing, CTAs, throughout the website, and also tying into any other pages, microsites, landing pages, is probably 80% of the work. And then the rest of it is tying into the rest of your marketing strategies. So thinking about what type of content strategy your marketing team has going. So, a lot of times patients will Google their condition and they'll land on your hospital's site to learn about that. They'll read through it. And if you think of what some other organizations do, Cleveland Clinic's a great example of this. A lot of times there's that call to action as you're scrolling through that says, get a virtual second opinion while you're thinking about it. And those are great ways to channel that traffic and interest into your specialties to your second opinion program, or whatever it is, pre-surgical, all of the forms that it can take. So in addition to that, you also want to think about your organization's networks. So you might already have, if you're a teaching hospital, you might have alumni networks, foundations that you work with, patient support groups, things like that. And then the next thing I would say to think about is the patient experience. So when we start down this road with organizations, we take a look at the whole patient experience beginning to end. And we like for that to be as seamless as possible and also branded, so the patient never feels like they're leaving your website. And part of this, making that a seamless experience, is setting clear expectations. So on your landing page for second opinions, outlining what that process is going to look like. They're not always exactly, or they're not exactly the same as a traditional in-person appointment. So the patients and patient families doing this really appreciate just understanding what to expect in that situation. And then the last piece on the experience is also outlining what to expect if and when they come in person. And I would say think about reaching out to a global services team. A lot of times they've already, if you have one, they've already outlined some of this, and that's like where to stay when they come in person, where they can go out to eat, things like that. And I'm sure I forgot something in that long list. The last thing really is benchmarks. So establishing those benchmarks and making sure you're checking in regularly. So if you need to adjust where those call to actions are because traffic isn't getting to where it needs to go, things like that. Josh or Les, anything else?
Yeah, I just add that, there are a lot of ways to get the word out. I think your comment about awareness is a good one. A lot of ways to get the word out to, the people who have done residencies at your facility, for instance. Samantha mentioned alumni networks, things like that. Um, but we've also seen programs be very successful reaching out to foundations, specifically if you're targeting a rare diagnosis, your physicians might already have relationships with some of those foundations, that some of those foundations provide other services and support. So if you tell those foundations that you're now running a program for their disease, then they might share that with the resources that are available to their patients. And so we've seen that be very effective as well for some rarer conditions. And we've also seen, if you get the word, your patients themselves end up being really good advocates for the program when they have good experiences with it. We were talking recently about a case that we had a facility that was seeing an East Coast facility that was seeing a spike in cases that were coming from Washington State. And we said, well, what's going on here? They started getting a whole bunch of cases, and they asked one of the patients where they heard about the program. Turns out that the mother had dropped the link to the intake form into a mother's Facebook group specifically for that condition, which I just think is a great example of how that type of marketing, that word of mouth, that endorsement by other patients, can really, really kind of expand and grow your programs as well. And so that's something, again, that if there are ways to get the word out through your patient networks, we know there are hospitals that have patient advisory boards, and we think that's a great idea. And letting them know about these programs and things they can share it with their networks as well. So those are just some other ideas that we've seen be successful. Obviously, there's a number more. Everything from different advertisements and different things that you could go into more marketing focused. But I think some of those individual touch points are some of the things that I think have been very powerful along the way.
Yeah, they go a long way, especially in this day and age when we're inundated with so much advertising, so many emails. Patients want to hear from other patients. So those patient testimonials are really impactful, especially, when you're launching a second opinion program, you've very likely already had patients come in person, and many marketing teams have already cultivated those stories and already have them that you can put on that page as an example of this is how these patients came in person.
Great.
So what about you, Les? A little quiet over there.
I think the obvious ones are, great links in obvious places. But one of the things we found is that actually internal marketing, so marketing back to your staff, so that your staff actually knows that you do remote second opinions. It's always surprising to us in some of the hospitals as they're starting out that there are silos of information and it doesn't get dispersed necessarily throughout the organization. So letting other people know is great. It also is how a pilot program becomes viral in your organization. So what happens is some division finds out that another division is doing this, that they've had some success doing it, and right away they want to join in and they want to become part of a pilot or a program themselves for their division. So internal marketing also is very powerful. And there are lots of people that work in very different capacities within a hospital, and they deal with lots of different contacts of their own, and those together can become viral.
Absolutely. That's a good one. Okay. So let's go ahead and start taking any last questions. We've received a few as we've been talking. So go ahead and type any other questions you have into the Q&A box, and we'll circle back to those. While we're waiting for those to come in, Les and Josh, do you have any other things that maybe we've missed or something that you'd like to emphasize?
We've been pretty comprehensive in the things we're talking about. From a pilot specific point of view, what we have found is that organizations can afford to pay for these right out of the operational budget of a division. So the nice part about this for them is they don't need to go to their capital budgets to get this. They don't need to put it in a strategic plan a year in advance to make these work. They're affordable from that point of view. It's a great stepping stone. It's a great starting point. And as they start to become successful, it is much easier to garner support of upper level management. It's easier to garner support of the CFO. It's easier to prove out that these programs actually have an ROI. So start small, fit it within your current budget, make it work, prove it out, get your sea legs under you, and go from there.
Definitely. What about you, Josh?
Yeah, I think, again, I think we've touched a lot of bases here. I think the comments that Les made that recently about how the internal marketing can really help with your organization's expansion, I think is a key point with what we're doing with the pilots, because I think we've seen that time and time again. A lot of it is around, hey, you have a great way of accepting medical images over there. Wow, like it can be something as what sounds simple as that, but that's the thing that they're spending a lot of time with in their department. They're wasting a lot of cycles because they don't have a really good way to manage these images. And oh, you found a way to upload and I can view those off on my cell phone while I'm on the run. Little things like that. I can review this case while I'm traveling from my iPhone. Things that I think today they might not have access to, and they might seem small, but they're actually very large when you start thinking about the actual time that goes in somebody's individual day. So we've seen programs expand based on those things, that you start in one place and then somebody's looking over saying, what are you doing over there? Oh, hey, you got one of those. Wow, I want one of those. And that's how things grow.
Yep. Okay, so I'll add a couple with my marketing hat on, that these pilot programs are a great way to channel interest to specialties that you'd like to feature, to expand your geographic reach. They can apply to different sizes of organizations and different types of organizations. And overall, just to sum up what everyone said, it's a lower cost, lower risk way to get started. So one of the questions that I got, I think, was based on what you were saying earlier, Josh, when you were explaining adaptive services. And that is it Purview's brand in adaptive services that is going out to the patient, or is it the hospital's brand that's represented?
Yeah, that's a good question. So typically we in all of our marketing, all the software and everything that's out there, it's going to be your brand that's front and center. And so we are putting, your hospital's logo, we're going under your subdomain. So it's a very seamless experience for the patient. When it comes to the adaptive services themselves, we can talk to you about how to best approach that with your organization to make sure that we are staying in line with the way that if you have a standard for how you interact with your patients. Typically, the patient will need to become aware that Purview is involved because there is a HIPAA authorization that typically is involved with releasing medical records, and so they have to authorize us and you as an organization. But it's a very collaborative approach, and so they see us very much as a go-between to your organization at that point, and so we can take some of that. And oftentimes facilities want that to be the case, that we act as Purview in that regard as a buffer, because they need to create a little bit of that wall between them when they're a patient, when they're not a patient. But we can work with your organization directly to meet whatever standards you have as far as branding or patient intake in order to optimize it for your organization.
Yeah, I think what I like about the adaptive services is that they're adaptive, we're flexible. Sometimes, Josh, your team handles just the medical records collection, for example, and an organization might want to handle that first interaction with the patient. So it's really up to the organization on how they want to handle that.
Yeah,
The next question. Oh, sorry.
Yeah, I was just going to say, good distinction. We can, and the other piece to that is too, we change over time with a lot of these organizations too. You're at a moment where your facility is growing and you haven't yet hired to staff it. We come on, we go up, you catch up with it. We can scale back down, and so we'll meet you where you're at, kind of across the process. But as Samantha said, some of them we just do records collection, and so it just depends on what you need, and we can provide that help.
Right. Okay, so this one's for you, Les. What role does medical malpractice play in deciding which geographies to accept?
Well, I can give you my cynical answer, and I would say they shouldn't play any role. They should actually just be beholden to the provider who decides where they want to practice. But what you want to do is you want to make sure that you bring your medical malpractice payer along, whatever you would want to call them. I guess they're not called payers in this world, provider along with you. So that means make sure that you've run past them the jurisdictions that you want to do business in. Make sure you've run past them what your legal basis is for having the licensure and being able to do that, and do that early. We have seen situations where medical malpractice insurers have given great advice to some of our clients about particular geographies that are very litigious, for example, that they don't suggest that they do business in. And that's good feedback coming from the medical malpractice provider. And that's something that you want to do. You want to do it as in concert, despite my facetious words. You want to do it in concert with them, and you want to make sure that you are all together in this, because ultimately it is that whole package, right? It's your ability to provide great medical services in a geography where you're legally permitted to do it and you're covered in the event that something goes wrong. All three of those need to go together.
Great. Okay, I think this is our last question, and either one of you could probably answer this one, and that is, you touched on it a little bit, but when a patient converts, how do the records get into the local EHR?
Yeah, so
Josh can handle that.
I'll take that one. So you can have a couple different approaches, right? So if you want to just be bare bones in your program, the easiest way to do it without any integrations is you can just export the records and upload them back into your system. That's kind of built out of the box. You can do that. So there's the ability to download records, re-upload them wherever you need to from within your own environment. That said, we also have integrations that we can create with whatever organization, provides your EHR or your PACS system, and those records can then be push button sent through an integration. And so we work with a number of different platforms. We can really send into any PACS system, or leverage something like an Ombra Connect. We can send into something like an Epic. And typically the way that it works is that you'll have the facility then at that moment, once you've said, yes, I want this patient to come in person, you'll create the MRN in your EHR system. We'll push the records and you'll link it together. So it typically ends in something like the Epic Media file or the Ombra activities log, and you link it all from there, the same way you would if you were getting external records in from Ombra in general, or one of those other facilities in general.
Awesome. Well, we're coming up on the hour, so I think we should probably end with that one. If there are any other questions, please don't hesitate to reach out to us. Thank you to Josh and Les for joining us today and sharing your experiences and expertise with us. So last but not least, just keep an eye on your email. We'll follow up with a few resources as well as the recording. So we have our Second Opinions 101 by the advisory board, as well as the white paper we talked about earlier, which is actually interactive. So you can scroll over the states and see which types of episodic exemptions are within each one. And then, of course, if you would like to hear more about how to start a pilot program or have any questions about starting a pilot program, just reach out to us. I have our emails on the screen here, or you could go to our website, purview.net. So thanks again for joining, and have a great rest of your day and rest of your week.
Great. Thank you.
Thanks, Samantha.